Welcome back. Now that we've talked about how perinatal loss related to a life-limiting fetal condition is the unique subset and discussed some of the conceptual frameworks that help us understand parents' experience, we're going to talk about incorporating what you've learned throughout this course into the practice setting. Complicated grief is a preventable outcome. There are approaches to healthcare interventions which may positively influence parents' experiences. According to the perinatal grief theory, there are three components to the experience which influence grief intensity. And that is the reality of the pregnancy. So is the pregnancy considered to be real? Is this the son or daughter that the parents are considering? Or is it more of an idea, just a pregnancy, not really anything actualized? So the reality of the pregnancy to the parents is one piece of this puzzle. Congruence is another component. Is the experience that is carried out consistent to what the parents desired their experience to be? And the final component in this grief theory is the ability of the parents to confront others. So those who feel they have the agency and ability to stand up for themselves and confront those they feel as being insensitive or not giving them what they need in their experience, they are likely to have decreased grief. So to recap, increased reality, decreased congruence, and decreased ability to confront others place parents at an increased risk for developing intense grief. Now, Dr. Huddy and her team took this theory and they developed the Perinatal Grief Intensity Scale, or PGIS, as a valid and reliable tool to assess parents' risk of developing intense grief. In my study on anencephaly that I've been talking about, I used the PGIS to measure parents' risk for developing intense grief. Now, in this study, 100% of the parent scores, including all of the fathers, indicated that they considered their pregnancy to be real. Now, because of this reality of a pregnancy complicated by a life-limiting fetal condition, parents who experience this type of loss are instantly at an increased risk for developing complicated grief. So there are several screening tools that can be used in the practice setting. The reproductive grief care course talked about the perinatal grief scale. I've mentioned the perinatal grief intensity scale. There are also several others. What is important is not which tool you use, but that you assess parents' grief intensity or risk for grief intensity, because only by identifying their risk through this assessment can you truly meet their needs and provide the resources that they need in this time. So, like I've mentioned, perinatal loss, unfortunately, is an inevitable reality, but that complicated grief following that loss is not inevitable. It is preventable. So let's talk about some things we can do to prevent that complicated grief. Offering parents control over their care is one of the biggest things that we as healthcare professionals can do to support parents during this time. Again, in the study I talked about, to kind of put this into perspective of why this control over care is important. In the study, 61% of participants expressed an inability to understand what a pregnancy complicated by anencephaly meant for them. 72% voiced concern regarding informed decision-making, and 92% felt misunderstood by the healthcare team. If parents are unable to understand what the meaning of a life-limiting fetal diagnosis is for their pregnancy, they cannot accomplish the developmental task of comprehending the diagnosis, and they cannot move on to that decision-making process that is needed to have to meet their goal of having no regrets. So allowing parents control over their care is one of the ways that we can address their needs. While this may seem obvious, the unfortunate reality is that commonly, the moment a life-limiting fetal diagnosis is detected, patient-centered care is removed from the situation, as well as shared decision-making. So what can we do about this? How can we incorporate patient-centered care, high quality communication, and shared decision making. Because these are three components that are very important in giving parents control over their care. Talking to parents about a pregnancy diagnosed with a life-limiting fetal condition is very difficult. Clinicians often feel unprepared and unsure of what to say. The fear of saying the wrong thing often prevents healthcare professionals from saying anything at all. This fear is perfectly normal. Healthcare professionals rarely receive the education and training they need regarding difficult conversations, particularly following a life-limiting fetal diagnosis. The topic is highly emotionally charged, value-laden, and unfamiliar. So again, thank you for taking this course and learning how you can communicate with parents during this difficult time. Essential elements of therapeutic communication translate well into conversations surrounding perinatal loss. Therapeutic communication comes from a place of humility. It's a willingness to listen to the patient, to learn of their concerns, and to prioritize care according to their needs. Therapeutic communication encompasses not only immediate physical concerns, but also the mental, spiritual, and psychosocial needs of the patients. Using therapeutic communication skills when talking to parents about their terminal pregnancy invites parents to share their concerns. It allows clinicians to assess the parent's needs, and it fosters that therapeutic relationship with the patient that is so important in providing high-quality patient care. By building these relationships, clinicians are then better prepared to advocate for patients and intercede on behalf of their individualized needs. Therapeutic communication is a critical component that empowers parents to achieve their overall goal of having no regrets following that life-limiting fetal diagnosis. The communicative stance is an important thing to consider when conversing with patients. 80% of what we say is communicated through our body language, and our tone conveys much more than the words that we use. While the tone and body language within the conversation convey more than the actual words, it is important to consider the words themselves. Words that are value-laden and biased may sway parents into making a decision that they're not comfortable with. For example, listen to the difference between these two statements. Most parents in your situation choose to terminate, but there are other options. Or, this is a very difficult decision. You have the option to terminate, induce, or continue the pregnancy. Time is also a critical element in communication. When our brains experience extreme stress, as in the case of receiving a life-altering diagnosis, information becomes very difficult to process. Parents may need to come back a few days later to discuss the diagnosis when they've had time to get over the initial shock. They may not be able to understand a single word you say, and they may not be equipped or even able to make a decision when they receive the diagnosis. Due to the highly emotional nature and level of importance of conversations surrounding life-limiting fetal diagnoses, it's recommended to consider this type of conversation as a high-stakes conversation. This means that the conversation is considered important enough to dedicate enough time and resources to it. So this takes into consideration not only that communicative stance I've discussed, but also the environment in which the conversation takes place. For example, is the woman still in a hospital gown with ultrasound jelly on her? Is the room cold? Is there a lot of noise? Is there high traffic? It's important to have a support person available as well. If the person carrying the pregnancy, if their partner is not able to be a part of the conversation, maybe asking if they want to wait to have that conversation until their partner arrives would be ideal. Giving the individual that choice offers that semblance of control. Asking if they would like to have the conversation now or in a different room also gives a sense of control. In this conversation, it's important to offer a warning shot, such as, I have some difficult news, or this is going to be difficult to hear. This allows the person to take a moment and realize we are going to talk about something important rather than just blindsiding them with a life-altering diagnosis. Again, asking if there's a support person they would like to have with them, or maybe bringing in another healthcare professional such as a nurse, a social worker, or a chaplain could be very important in this conversation. So in high-stakes conversation, it's important to remember the importance of the conversation, the warning shot, the environment in which that conversation takes place, and allowing the individual to have some control in what happens in that conversation. Patient-centeredness is a pillar of the 6 domains of high-quality healthcare. Patient-centeredness considers the unique needs, desires, and beliefs of the patient. It is a respectful and compassionate approach to patient care, which brings the patient in as a partner rather than dictating what happens to them. Surprisingly, according to the experiences of individuals in the study I've mentioned, as well as studies in the literature, the moment a life-limiting fetal diagnosis is detected, that patient-centeredness no longer becomes a priority. That's why it's so important to alert yourself to this thought. Life-limiting fetal diagnosis requires high-quality communication, patient-centered care, and shared decision-making. It requires patient engagement in the conversation. That means the patient is allowed to discuss and ask questions. It dedicates time to the conversation rather than simply saying, this is the situation, this is your option, what do you want to do, and making that decision in that moment. So in this example, in this situation of life-limiting fetal diagnoses, it's important to take the necessary time to allow that patient-centered care and to foster that shared decision-making process. Particularly because the goals of pregnancy are revised following a life-limiting fetal diagnosis. And this means that the decision-making process also changes. Rather than basing decisions on risk-benefit ratio, decision-making is more heavily swayed towards value systems. Parents become concerned with making decisions that they can continue to live with. Respecting parents' decisions, assessing their needs, and allocating bereavement resources is critical in this situation. Unfortunately, as we've mentioned, perinatal loss is inevitable, but that complicated grief is not. And healthcare professionals, you all are critical agents of change in this situation, and you are advocates for these parents. You are capable of decreasing the grief intensity and the grief trajectory of those experiencing this type of loss. While difficult, that's an exciting place to be as healthcare professionals. And as we've discussed, placing parents in control over their care is one of the most important things we can do to mitigate the risks of complicated grief. And again, considering the conversation surrounding a life-limiting fetal diagnosis as high stakes, offering that warning shot and altering the environment really sets the tone for the decisions made and the care that follows that pregnancy. Other critical components include bereavement resource allocation and especially follow-up care. Bereavement resources for parents experiencing perinatal loss are unfortunately scarce, which I learned in my own experience. There are resources available, however, in some communities, in some hospitals, and online. There are several organizations, such as Life Perspectives, which offers that continuing education. There are organizations such as Forever Footprints, Sufficient Grace Ministries, or Project Poppyseed that offer support to those parents. So using these resources is an important tool that you can bring into your healthcare system. As I've mentioned, patient care following a life-limiting fetal diagnosis is rarely addressed in pre-licensure training or curricula. Without that training and education, we obviously cannot expect healthcare professionals to know how to respond and care for parents with this experience. This means also that facility practices and policies are likely inconsistent with parents' needs. The education that you've received throughout this course makes you an ideal agent of change, and it's important to you. I invite you to look at some of the practices in your healthcare system and identify areas that can use improvement. As part of your course materials, you've been provided with a worksheet that offers possible areas of change that I encourage you to look through. So take a few minutes, identify some areas that could use some practice changes, and identify some key stakeholders who can help you make these changes a reality, such as a manager or a supervisor. When you come back, we're going to walk through some case studies so that we have practice putting what you've learned in this course into a specific patient care situation.